First of all, can everyone see the slides on the screen that I'm sharing? Yes, okay, excellent. So we're going to talk about a variety of things that are pulmonary toxins. I think the key point, the key take-home message slide on this is this one here. The most important property of all of the things we talk about is solubility in water. So gases, fumes, aerosols, and we'll talk about the subtle differences between those that have high water solubility properties react when they reach the water of your mouth, your nose, your throat, your eyes. They rapid onset of symptoms because um, they are so highly water soluble. Because of this, when they react, usually there's some sort of acid or irritant that's formed, and so therefore they have good warning properties. And therefore, if you're able to walk away or escape the situation, you will. If you were working with ammonia, for instance, and you spilled a bottle and the vapor went up in the air, the noxious odor of ammonia would pretty much cause you to walk away and come back later, maybe clean it up. Not everybody does that. Some people keep working through the pain, and therefore we get people with more significant exposures. But in general, the highly water soluble agents don't go very deep. It's all upper airway, stridor, and less wheezing. To contradict those or factual those are the low water solubility agents. This we often talk about the prototype of being phosgene, which is a little used war gas from World War I, but it smells very pungent like fresh mown grass or hay and doesn't smell very different than being out in a field. It doesn't react very well or quickly with the water in your upper airway, and therefore doesn't really have any poor water warning properties and doesn't even smell bad. And therefore, people will stay in the environment for much longer periods of time. But eventually, through inhalation and exhalation, it will get down deep in the lungs, and the phosgene will react with the water in your lower airways and produce an acid, a chlorous acid, hydrochlorous acid, and that will develop a slow onset of acute ARDS or pulmonary edema. Now, there are substances that are between the highly soluble ammonias and the low soluble phosgene, and chlorine sort of sits in the middle of those. But this is sort of the key to whether something is going to cause upper airway stridor or lower airway ARDS. There's a couple other definitions, and it's always a little confusing. A vapor is simply either mostly a liquid, but sometimes a solid that's dispersed up in the atmosphere as a gas. Usually it's produced when a liquid or solid is heated to an adequate point, a vapor point, and it evaporates. For instance, you could heat water, and right above the water is steam, and that steam is a vapor. There's a few interesting chemicals that go through a process called sublimation, remembering back maybe chemistry in high school. These are uncommon. They go directly from a solid to a gas without going through that transient liquid phase. The most common one that we'll ever hear about is dry ice, which is frozen carbon dioxide. It will sublimate directly to vapor carbon dioxide in the atmosphere and therefore displace oxygen. The other one that sometimes comes up is one formulation of mothballs, the naphthalene, can go from that solid little mothball to vaporized naphthalene. The vapor concentration is the amount of vapor released from the liquid, and there's different ways of measuring this atmospherically. A lot of this lecture will be about hazmat response and things we might hear from them. The most common way is parts per million, but it also can be measured in milligrams per cubic meter and percent. Most likely you will not be asked to convert these on a test. And you're not expected to remember what thresholds are. But these are used for occupational regulation and recommendations for how long you could stay in an environment of which there's a vapor concentration of a solid or liquid vaporized into the atmosphere. The term that may be the most important is called IDLH, immediate dangerous to life and health. That's defined as a concentration that if you were present in for 15 or 20 minutes at a minimum would produce severe physiologic health effects or death. So it doesn't have to be death, but it can be immediately dangerous. And a lot of chemicals and properties have an IDLH level. A lot of alarms in manufacturing and even the carbon monoxide detectors in our homes trigger way below the IDLH level because they want to give you adequate warning at a non-toxic or subtoxic level to leave the environment because the concentration is rising. Liquids can aerosolize. It can either do this from as a mist, liquid droplets suspended in air, mechanically produced from breaking it up, sometimes a process where it's being splashed or foamed or whipped with metallic blades of some sort, and there's a mist above it. So this is something that's rising from agitation of a liquid above it and creating an aerosol. A fog, however, is more of a condensation where visible suspension of fine liquid and gas happens when the temperature gets to a certain level, like condensation or cooling. Solids similarly can produce aerosols, and there's some subtle differences. The differences between smoke, fumes, and dust, depending on the primary process for generating those solids. A smoke is by incomplete combustion of organic processes. A fume is produced by heating, vaporization, or oxidation of a metal. And we think of this, let's say, with metal fume fever, where we may be soldering with a liquid solder and it's vaporized by the heating device and it produces a fume. Inhaling that fume for a long period of time can produce a pulmonary reaction called metal fume fever. Dusts are solid particles that are suspended in air, mostly from breaking up mechanically. So if someone's working with a jackhammer on concrete or scrubbing cement with a sandblaster, those dusts from that can produce enough particles to cause problems with inhaled silica dust, perhaps, in the concrete example, or other dusts that are associated with occupational diseases. So taking everything into account, what causes toxicity has to do with, as we mentioned, the most important one is water solubility, depending on how deep into the lungs it goes. Part of it has to do with how long the person is exposed, to what concentration they were exposed. Were they above the IDLH for a long period of time? Certainly their underlying health and how fast they were breathing. Were they running and therefore breathing faster and inhaling more? That's going to make them more susceptible. And then other properties like we talked about, the volatility of an agent or oil a low volatility oil may not vaporize very well, but if you drink it, it may cause more problems by aspiration. This is probably a little bit above and beyond what may be on a test, but when they do a hazardous material response, if they can get detectors up and around the site of release, they can define these 3 or 4 levels of AEG levels, where 3 could produce potential fatalities, where you have to evacuate from that zone. Level 2 have moderate effects, especially in people with pulmonary disease and cardiac disease, where they may have to shelter in place, or the highest risk people may have to be evacuated. And then level 2, those people can probably just been in a warning range. They can essentially just shelter in place. And the green zone or level 1, there's probably no adverse health effect, but often due to people being on social media or listening to the news will present for evaluation because they could have been exposed or they thought they were exposed, or maybe they smelled something or saw somebody else coughing or having an exposure, and therefore they're starting to worry. Typically what happens is the people at the exposure site and in the red zone, those may be fatalities, and as further away you get, those are the more of the worried well, walking wounded, who overwhelm systems, and often we, even part of the Poison Center, get calls from. Again, this is just another way of doing these acute exposure guidelines and the level of care that they may need. So what happens when something actually happens, a car full of chemicals tips over, or a railway has an accident? Locally, and this is not going to be in the test, they notify ORS, who notifies, at least by protocol, should be notifying us, and this doesn't always happen. Usually, if there are people involved in the cleanup or the exposure, we should be notified. But if it's just a chemical leaking on the ground in a field somewhere, we may not. So these are statistically the variety of gases and chemicals that are involved in accidents. The big two, which we'll talk about in some detail, are ammonia is number one, and chlorine is number two. But I did want to mention another one that is on there that doesn't get a lot of attention as far as mishaps, but we get a lot of calls on, and that's fluorine. These placards are on the side of rail cars. They're on the side of trucks. Sometimes it's hard to read because something is smoking or burning. But if we can get the information, this can all get looked up. These ID numbers are unique to each substance. And you can download this now. It used to be called the Emergency Response Guidebook. I always had one in my glove compartment. It's probably as old as the last version that came out. But if you get go to the app ERG 2016, you can put it on your phone now and always have it with you. So a little bit about hazmat response and hazmat suits. These potentially may be testable because they do cover sort of terroristic threats, but realistically, you probably won't see terrorists, but we will see industrial accidents, which are pretty much approached similarly with the levels of hazmat suits. Level A is a fully encapsulated suit with usually neoprene gloves and sealed off booties and an enclosed oxygen tank. Oh, someone says the ERG 2020 is now available. I will upgrade my slides accordingly. So that's new data. So level A is not, somebody has to be fully trained. You can't just get somebody and say, hey, we need your help, put on the suit and go in there. That shouldn't happen. Even level B, which still requires the use of a scuba tank in the back, but may not have complete encapsulation around the head, should not be something that's impromptu ask somebody to don and put on and go in and help. The highest level you should ever be asked to don in an emergency situation is level C, which is basically gowns, gloves, usually a Tyvek suit, maybe open around the forehead, but you can wear eyeglasses and a mask. Some of them have pappers, which go over, which are these plastic hoodies that go from the top of your head down to your shoulders. They're open at your shoulders and they sort of blow air from the top of your head downward, creating a pressure gradient so fumes and gases don't penetrate into your breathing space. And level D is basically your typical hospital gown and gloves wear. Here's a summary of all that. I'm not going to read it again for you, but you can just take a look where level A is for gases, vapors, and things that are going to be in the atmosphere that you have to completely block out. And level C is where there may be selected vapors or aerosols where you just need to work on them. Presumptively, the patient has been decontaminated in the field first before they're handed off to you in the hospital as a level C dressing. This again is also a diagram of how things are set up. The hot zones where the event happens, nobody should go in there except through the entry and passage. They should be fully gowned up, usually level A or B to enter the zone. Their goal in the hot zone is just rescue, not therapy. Once they're brought out to the warm zone, they can be re-triaged to those who need antidotes and immediate care to those and the rest of them that need to be washed off. Everybody should be washed off thoroughly, stripped down completely in the warm zone, and sort of emergent antidotes. And we'll talk a little bit with pesticides, with using auto injectors full of atropine and tupam, maybe the only, or even epi for an anaphylactic type reaction, maybe the only thing that you can really administer in the warm zone. After that, you're then triaged out to the cold zone, where you can be retriaged into mild, moderate, and severe. The severe ones get transported first. The moderate and mild ones may receive instructions about when they're going to be transported or what they need to do to either self-care for themselves. Again, it's all part of a hopefully well-developed, pre-planned, and tested plan for hazardous material response. So I want to talk about 3 or 4 chemicals that always seem to show up. And we do get calls on hydrofluoric acid. Comes in a variety of sizes and concentrations, and for different uses. This is the symbol, if you ever see it on the side of a truck. This 4-part symbol. The blue is the health risk, which is high. 4, the flammability, which is 0, which is none, and the reactivity, which is minimal, which is 1. Sometimes there's a 4th square put in there. It's something like explosion or caustic or something else is filled in the last box, but that's not the case for HF. At home, these may be used for rust removing, cleaning up tires, glass etching hobbyists, people who sometimes have their solar panels installed and cleaned, sometimes in tanning. In more industrial uses, it may be used in polishing and oil refining, electroplating, and the manufacturing of a whole variety of substances such as pesticides, plastics, and octane fuel. And which concentrations to that is dependent on what it's used for. The low-end hobbyist ones are usually 3 to 5%. The higher-end 50% and higher ones in industrial processes are very scary and very dangerous. The aqueous hydrofluoride comes in 3 up to 40%, and 40% is a pretty scary amount. There's also ammonium bifluoride, which is slightly different than HF. It's NH3F2, so there's 2 fluorides per molecule. So lower concentrations releases twice the amount of fluoride. This is often used as a wheel or a steel cleaning property and available at home. The anhydrous amount is the highly concentrated, usually above 50%, and it creates fumes, so it vaporizes above the liquid itself. And so people working with this in industrial processes have to be fully encapsulated and have protection for their breathing space. Above 67 degrees Fahrenheit, which it probably is right now, it becomes a gas and becomes essentially a fuming acid. So as an acid, it's not a really strong acid as far as producing widespread systemic acidosis, but its notorious aspect is it binds usually bivalent cations such as calcium and magnesium, producing severe hypocalcemia and hypomagnesemia, both of which can lead to arrhythmias. There's a little bit of a later phenomenon that happens with muscle injury and tissue injury, and they release potassium, causing hyperkalemia. So those are usually the 3 testable electrolyte abnormalities. They may say someone's exposed to this chemical that's used for glass etching. Which set of lab electrolytes would you expect? So the ones that show low calcium, low magnesium, and high potassium would be the right answer. The way why these are scary, especially at the higher concentrations above 10 or 20% HF or 10% ammonium bifluoride, is this eventually leads to, within a few hours, hypocalcemic induced cardiac arrhythmias, and they can go into torsade and refractory ventricular tachycardia quite suddenly, sometimes without the QT prolongation that we're used to looking for. It may be subtle or minimal, and they'll just have cardiac arrhythmias that are extremely difficult to resuscitate. The people who develop this also don't really seem to hurt that terribly badly while they're working. It's usually they go home and they notice their fingertips are numb or tingly or having paresthesias at the end of their fingers or hyperalgesia at the end of their fingers. And it may just look like they left their fingers in water too long. Here's another one, very subtle, white fingertip on his pinky where maybe his glove had not been sealed completely. And some other ones, again, very subtle blanching, but not a classic burn with a blister. So the treatment, first aid, is to put calcium on it. You can use calcium gluconate or calcium chloride topically. Those 2 don't matter. Now, historically, we've always said you can crush it into some sort of jelly like petroleum jelly or Surgilube or um, any sort of ultrasound gel. But it turns out probably not testable because it hasn't been out there yet. We've found, mostly Colleen has found here, that it precipitates out in the jelly and it forms like a calcium layer that's not very useful as far as getting it into your skin. So really, I think just putting calcium liquid, gluconate or chloride onto a gauze or just putting your fingers directly into it are probably the right way to go without needing to actually find something to put it in a gel form. Anything that's above 20% HF or 10% ammonium bifluoride probably should get an IV, and at least in the field, potentially should get a dose of calcium gluconate, which is the preferred peripheral IV medication because the chloride is a bit caustic to veins, and you should have a large or at least a central line for those to give chloride. Sometimes they sell as commercial products. Here's some pictures of calcium gluconate gel that's sometimes kept in places where they use this for HF for cleaning auto parts or for solar panels. This is fine as first aid therapy. As far as the difference, and again, this is an often very testable question, what's the difference of the ratio of calcium and gluconate versus chloride? So chloride being a small molecule by weight has 3 times as much calcium per unit of measure, so 13.6 milliequivalents. Whereas gluconate, being a larger molecule, has 1/3 of that. So it's a 3-to-1 ratio. So a gram of calcium gluconate only has 4.6 milliequivalents, but a gram of calcium chloride is 13.6 milliequivalents. And again, we don't use the calcium chloride peripherally because it can sclerose the vein and cause wound problems. A little controversy about what to do with a pulmonary exposure, but if you were in an industry where they're using anhydrous HF and it was a fuming anhydrous HF and you breathe it in, even just a little bit of it, I think putting calcium gluconate in an asthma inhaler as mixing it 3-to-1 with saline or water and just having people breathe that in will probably help get some of the HF that made it to the upper airways reacted with the calcium so it doesn't cause the intrinsic hypocalcemia that might happen. Now remember, this is probably not going to get very deep past the 3rd or 4th branching bronchioles, even when you're using this as an asthma treatment. So we have topical, we have inhalation. There's a couple other things we can do. We can use subcutaneous calcium gluconate again, not calcium chloride, where we can take an insulin syringe and dilute it down and inject it under a fingertip if it's just one fingertip, or on an open surface of an arm or a leg. If that doesn't work between topical or local, and then you may need to go to either systemic IV, calcium and magnesium salts, which is just giving a slow infusion IV of calcium, or what we call regional or Bayer block. Bayer block basically works like this. You blow up a blood pressure cuff, you elevate the arm, you wrap a bandage around it to kind of squeeze the venous space so there's no blood in the veins of your arm. And then through that now distal IV, you can slowly infuse. Typically in a beer block, they put in lidocaine and it makes your whole arm below the tourniquet numb. But in this case, we would put in calcium gluconate again. It's the one we give, like an amp of calcium gluconate, wait about 15 minutes and see if your fingertips are now starting to feel better. And then you can slowly let the tourniquet down. Here's sort of a picture of it in real time. As far as splashes in the eyes, this probably goes for every chemical. As if you're working in industry, get to the eye wash station that should be located within 100 feet of your work area by code, and just flush. If not, just you can just go have someone pour water in your eyes, or if there's a shower room, get into the shower room and do that for 15 minutes and open and close your eyes so it gets into all the crevices, and hold your eyes open with your fingers so you get to all the areas irrigated. If they're still having symptoms when they get to hospital, putting in a local anesthetic like proparacaine and continuing irrigation is probably the way to go. And then flipping over the lids, looking for paste or particles if it was like a solid or a blast kind of thing. And at the end of it, we can test for pH with pH paper to see if it's in the normal pH 7 range, or you can go about 6.5 to 8, 7.5 is probably okay after irrigation. And if it's not, if it's significantly acidemic or alkalemic, then you just keep irrigating. And they may need more anesthetic, that's fine. We talked about the Morgan lens. I personally am not a big fan of it, but people use it because there's a convenience factor to it. I would say until you've looked at the eyes and make sure there's no grit or something that's being trapped underneath these lenses, I think they're a little bit a risk of causing further problems sometimes. Here's a picture of a bad burn to the eye. I don't know. I forgot what the burn was for. Oh, hydrochloric acid. And you can see the whole air surface of the eye is peeled back. You definitely would not want to put a Morgan lens over this and make the injury worse. So that's fluoride. Also on the periodic table in the halogens is chloride. It forms its own gas, chlorine gas, Cl2. It's used for all sorts of manufacturing purposes. Locally, it's in the paper and pulp industry quite a bit. Household bleaching agents, water purification, swimming pools, wastewater treatment. The U.S. makes millions of tons of this. And unfortunately, we have several railway accidents that have occurred, and notoriously, each taught us unfortunate lessons with this. There's one in Montana in the 1990s. It always seems to happen in the middle of the night, going around a turn, maybe when people aren't paying attention. In this case, 4 tanker cars overturned, derailed on its way to a paper mill, and all this chlorine was spilled. In this small little town, 500 patients descended on the emergency department that was probably built to hold only a handful of patients. 352 of them ultimately were hospitalized, I don't think all locally, and 1 person died. Graniteville, South Carolina, also in the wee hours of the morning at 02 dark 100, 90-ton chlorine tanker ruptured, releasing gas as it slowed through the middle of the town of Graniteville, which also had a single hospital. So what are the chemical properties? Why do we worry so much about chlorine? Well, chlorine is always the prototypical middle solubility gas. It's not high solubility and it's not low solubility. Unfortunately, by being middle, it gives you both upper and lower airway injuries almost simultaneously. So it's got reasonable warning properties. I think most of you know when you walked into a swimming pool that was over chlorinated by accident, you can tell it starts irritating your eyes pretty quickly. In its pure form, it's kind of this green yellow, it's pungent, it definitely smells abnormal like bleach. It's got this intermediate water solubility and a vapor density that's heavier than air, so it tends to descend, and you can sometimes see this green yellow cloud near where these tankers have uh, broken apart. Unfortunately, this one has an explosivity property to it, and so that last box, I don't have the matrix for it, would actually have a little explosion icon in it. Couple of lessons learned from Graniteville. The initial report was it was sodium nitrate. So the good news was that's a really bad thing, but the bad news is they got it all wrong in what they were preparing for, if they were preparing at all. They didn't realize it was chlorine until over an hour, and the people finally got to the ER, and the sort of scene started to be evaluated by the first responders and hazmat team. So always assume whatever they tell you up front is not 100% true. Keep getting verification for how it's verified. There were 9 deaths in this incident, 529 people sought medical care, 69 of them were hospitalized, several critical, and they had to evacuate a city of about 5,000+ people for a mile radius around the crash. So lessons learned from many of these things are things happen in the middle of the night due to fatigue, contributes to both mistakes being made in the transportation process or the sealing process in factories, and also how quickly and how fast and who's available to respond to these incidents. Communications to the public was poor to absent. That seems to happen in every single one of these cases, including what was told to first responders, and I imagine the Poison Center at the time, who thought it was sodium nitrate, may be gearing up to treat for methemoglobinemia, which chlorine does not cause. And a lot of people who were not particularly injured showed up at the hospital anyway, and so hospitals need a plan for what to do with the sort of possibly exposed but generally healthy people, and how to triage those from the people who are actually exposed. So the third chemical I want to talk about is anhydrous ammonia. This one is the most common transportation accident that occurs, but it also is used in far more processes, including plastics, fibers, resins, explosives, disinfectants, household cleaning things, and also, coincidentally, in the illicit manufacturing of methamphetamines, which used to be a more mom and pop kind of business in the United States, but we've sort of shifted most of that south of the border, and now it's more of an importation problem. Um, it's the third highest production volume chemical in the United States with 9 million metric tons, and it's usually liquefied from a gas into a liquid in these pressurized tankers, rail cars, refrigerated barges, etc. And when they crash, they break open, and the release capability of going from a liquid to a vapor, as we saw, is pretty substantial. It's colorless, but as you all know, if you've smelled ammonia while cleaning, it's got a very pungent odor. So it's got great, excellent water properties with a low odor threshold. It's the classic highly water soluble agent, meaning that it's going to start reacting right away with the water in your eyes and your nose. And hopefully you will evacuate yourself from exposure, but some people work through minimal level exposures anyway. It's highly reactive, and its IDLH range is 300 parts per million, which is on the medium low side. So if you keep working in an environment that's exposed, you can actually have significant health effects, mostly pulmonary. Another railway accident in North Dakota. The air temperature here was important because it helped keep the amount of ammonia spilled down, because it was -6 degrees Fahrenheit in January when 31 cars derailed going around a curve. It released about 150,000 gallons of anhydrous, that pressurized ammonia, from 5 out of 15 cars that were broken apart. One car actually went airborne and struck a home. There was a plume 30 feet high spreading at 5 miles an hour downwind. The good news was the cold air kept it near ground level, but that's, of course, where everybody lives and breathes. This was sort of a map of the incident that happened just outside of town. And of course, the wind was blowing in the wrong direction, completely over the town of Minot. They did give a shelter-in-place order, but there was all sorts of communication problems. Population 11,000 plus. One was fatal, 11 serious. Seems to reproduce the same numbers we saw with these other rail car instances. And you can see the foggy, cold haze in that city at night from the ammonia spreading over it. What happened with communications? Again, a little bit beyond what we need to know for the test, but the 911 system was jammed. The air defense sirens couldn't be heard. People had the wrong information for 30 minutes or so. People kept calling and asking for what the hell is going on, and no one knew. They tried to tell people to shelter in place, but nobody really understood what that meant, and they started leaving their homes. They tried to put the word out on TV and radio, but both of those stations were closed for the night and just playing a continuous loop of Muzak over their airwaves at the time, and weren't able to intervene and broadcast anything. So that was one area. The other thing we see is there's a lot of ammonia in meth labs. We see less of this being produced in people's small homes, barns, storage lockers, hotel rooms, but a few years ago, this was a big problem. Every once in a while, something does leak or explode, and it's usually either meth manufacturer or sometimes more recently butane hash oil manufacturing that causes these explosions. There's a lot of things that go into methamphetamine production. I don't want to go over it, but besides the ammonia, which is an essential ingredient, there's other acids, other solvents, things like iodine and phosphorus, which have their own reactivity and phosphorus for ingestion that can cause hypocalcemia itself. And all of these can produce eye injury and lung injury. So again, the important aspect of this is to remember high versus low solubility, very testable question. High solubility, stridor, upper airway, risk of needing to be intubated because of airway constriction. Low solubility is delayed onset. People stay in the area longer. They inhale it deeper in their lungs and they get a delayed ARDS from it. These are the big four things that typically come up as far as questions: ammonia, high solubility; chloride, intermediate solubility; phosgene, which is actually COCl, there is no phosphorus in it, has a low water solubility; and HF has high water solubility, but has the unique electrolyte depleting properties that make it a cardiac toxin over time, and that over time is over hours. So that is part one. Part two is about smoke inhalation itself and carbon monoxide. I figured most of us know more of this since these are calls that we get more frequently. Where do we see, first of all, carbon monoxide from? It's any incomplete combustion, burning homes, burning wood, improper maintained heaters, people using propane heaters after power failure, people sitting behind houseboats, forklift drivers in small warehouses, Zamboni ice machines. For some reason, they love that. There's the sound of Zamboni. They might give you a question on that. And pressure washing, which we have seen. Someone's pressure washing. Like my neighbor is out there, except he's out in his open driveway instead of inside his garage. It's probably at high risk for if he goes down, I'll have to run out and drag him to fresh air. Carbon monoxide is a dose and duration problem. At low doses and short durations, it seems like you have the flu. You got a headache, you have muscle aches, you kind of feel achy and fatigued, but you don't have a fever, which is one big clue, and you don't have a cough or runny nose that often goes along with the flu. And unfortunately, these events tend to happen more in winter when flu and cold season is around. So people have those symptoms without appropriate infectious etiologies like runny nose, cough, and sore throat. You should worry about carbon monoxide. As levels get higher, it tends to be both a cardiac and neurologic toxin. It will produce altered mental status, confusion, all the way up to seizures and coma, and in high exposures, death. Cardiac-wise, it can also produce some chest pain and arrhythmias. If you buy a carbon monoxide alarm for your home, is always a good idea. It will sound loudly at these parts per million over these times. So it's a dose versus duration that'll make it sound. Just for point of reference, the IDLH, remember, the immediate danger to life and health, which would be 20 minutes in that concentration, would produce a significant risk to your life, is actually 1,200. So when it sounds at 70, 80 parts per million, it means it's been going on for a while, usually a few hours, but that's the time you might want to figure out where it's coming from, get out of the house, open the windows, and then have someone come in and check all your heating devices. A couple of things that are both real and testable are how we can measure it. So pulse oximetry, which is used as the fifth vital sign, does not detect carboxyhemoglobin. Carboxyhemoglobin has basically the detector shines these little microwave infrared lights through your fingertip, and it reaches the detector on the other side of the fingertip, and it analyzes the algorithm of how much is diffuse versus how much is reflected. And it basically tells you how much of your hemoglobin is saturated, and it actually doesn't care what it's saturated with. So if it's saturated with carbon monoxide, it'll look the same as if it's saturated with oxygen, and therefore it cannot detect the difference between those two. Now, methemoglobin, which we'll probably mention a couple of times separately, does something different to the hemoglobin, and it actually makes a pulse oximetry read at 85%. So if they give you someone exposed to a mystery gas and their pulse ox is 85%, think of methemoglobin. if they're exposed to a gas, but they have flu symptoms, but the 100% pulse oximetry, think carbon monoxide still. Now, there are these new pulse oximeters. They're owned by 2 or 3 different companies now. They can actually, through using 7 different infrared wavelengths, measure directly oxyhemoglobin, carboxyhemoglobin, and even methemoglobin. You can get an immediate readout. We actually have one in our emergency department. And so if there's a case where you suspect it and you want to non-invasively check or at least screen for if it's elevated, you can ask them to put this on their fingertip and see if it indeed shows elevated methemoglobin or carboxyhemoglobin. But the ultimate way to check for those is by drawing a blood gas. It doesn't have to be arterial, it can be venous, and you can directly from the blood gas lab, not the chemistry lab, the blood gas lab can tell you the carboxyhemoglobin and the methemoglobin level in that syringe. A couple of sort of myths. They say, oh, when you're exposed to carbon monoxide, you turn red all over. Only after you die will you turn red. That doesn't really happen during someone who's still alive and maintaining. So carbon monoxide is what we call a systemic asphyxiant as opposed to a simple asphyxiant. Simple asphyxiant just displaces oxygen from the environment. If I was to fill up a room with something completely inert like helium from a balloon, the FiO2, the amount of oxygen in the air, would slowly decrease. When it gets around 15%, everybody in that room will pass out because most people can't breathe an FiO2 of 15%. We need higher teens or 21%, which is room air at atmosphere. Carbon monoxide doesn't do that. It works at much lower levels before it actually displaces oxygen from air. It is a systemic asphyxiant, means it does 2 things. One, it binds with hemoglobin itself with 240 times the affinity of oxygen. And it also changes the binding capacity of the hemoglobin that's not bound with carbon monoxide and shifts it to the left. So it offloads what little oxygen is left less efficiently. And therefore, the end result of that is to decrease the oxygen release at tissue levels, the oxygen delivery to all tissues. And it is preferentially bound by both hemoglobin and by myoglobin, including myoglobin in the heart. And when we see that in the heart, that's why sometimes we see people have a chemical troponinitis or chemical myocardial injury. It's not an ischemic injury from low flow, it's a generalized release of troponin from the myoglobin due to carbon monoxide binding to it. The thing that it does that's the most lethal is it interferes with the electron transport chain at the last enzyme called cytochrome oxidase A3, and therefore pushes everything over to lactic acid. So here's a couple of diagrams of that. Here is your hemoglobin molecule, which is a tetramer, 4 equal parts of iron in the Fe+2 modality. Each of those Fe+2s capable of binding one oxygen modality. As carbon monoxide comes along, it'll displace it sequentially from each one, and eventually none will be delivered. But let's say you're just displacing 1 or 2, it makes it harder for the remaining 1 or 2 or 3 oxygens to be released to the tissue because of that left shifting of the dissociation curve. So the big points to remember is it shifts the hemoglobin curve to the left and delivers less oxygen. As far as what it does at the mitochondria, which is in all of our tissues except red cells, it inhibits the ability to produce ATP, which is the energy form in our mitochondria and all cells, and this leads to lactic acidosis. Sometimes, we end up needing to make a decision, are they sick enough to go to a hyperbaric chamber? And this is super controversial, and I don't think they're going to hold you to any sort of set criteria other than they might say, consider hyperbaric treatment. This is what a chamber looks like. It's like a little mini submarine that I can put you into and increase the pressure. What hyperbaric oxygen does is it decreases the half-life of the carboxyhemoglobin, but that's really not why we're treating. It can also increase the amount of oxygen dissolved in blood in the serum of the blood tenfold, but that also isn't exactly what we're treating. It can accelerate the dissociation of carbon monoxide from that cytochrome oxidase, which that is probably important. But the other things it does is it probably limits the amount of lipid peroxidation or free radical generation, mostly in the brain, especially watershed areas of the brain like the basal ganglia, and therefore ameliorates the risk of sort of subtle neurologic sequelae, which has been described with people exposed to carbon monoxide. So the reason we treat is to improve your neurologic outcome to the best possibility. And therefore, our threshold is a little variable, but probably one of the most important things is how easy is it to get someone to a chamber. There are more and more states and cities around that do not have these. For instance, in Alaska, we don't have any. And sometimes it's even hard here in Oregon to get someone to a chamber. You would have to be pretty sick, I think, at this, because I think the threshold goes up. So if there's any loss of consciousness or any neurologic symptoms that are there after resuscitation, those would be good criteria for perhaps having a discussion with the hyperbaric people. This is the St. Vincent's chamber. That's actually the guy who runs it. I think they're going to be closing soon, unfortunately. The big reason we use it in the United States is based on this article by Lyndall Weaver and others out of Utah. And Utah is very aggressive still in using carbon monoxide. What they did is they randomized people who presented over a 7 or 8 year period. If they had elevated carbon monoxide or acidosis, they either got sham dives or real dives, 3 of them, and then follow-up dives. So they had to be exposed within 23 hours, get to the test facility in Utah, get enrolled within the last hour, and they either had 3 hyperbaric dives in 24 hours or 3 normal baric dives, and they did all this neurologic testing in between. This was the first dive where they either went up to 3 atmospheres for an hour and then down to 2 atmospheres for another hour or so, or they just went back to sea level. And the second dive, they didn't go all the way up to 3, they only went up to 2, but versus sea level. And they basically ended up randomizing 76 patients to each arm. And at 6 weeks, a priority cerebral cognitive dysfunction testing showed that 46% of the normobaric group had cognitive dysfunction versus 23% of the hyperbaric group. Now, people have argued about what is the impact of this cognitive dysfunction. Was it sort of a reaction time of only a few seconds that were off? Was it the inability to follow a naming set of tests or a trail set of tests? But these are generally accepted neurologic impairment tests. And so at the time, and still, I think people say, if available, hyperbaric is the way to go. These are, in general, if you see it on a test, might be the reasons to put someone in a hyperbaric chamber. Loss of consciousness or persistent altered consciousness despite resuscitation or neurologic findings on exam. Those are probably the big ones. The elevated troponin and cardiac involvement is sort of a nice data point. You can say, see, they really were significantly injured because their heart was involved as well as everything else. The criteria for pregnancy is a little bit arbitrary, but I would possibly push for it more so, especially if there was a loss of consciousness in pregnancy. Older age is often talked about. I don't know if that's all that critical, but sometimes that's a testable point. People over 45 do worse, so it's not just over 65. So a little bit about cyanide in the last few minutes. In fires, we have both carbon monoxide from everything that's carbonaceous that burns, like wood, but everything that's plastic that burns produces cyanide. Cyanide has less warning signs. It's often said that there's this bitter almond smell to potassium cyanide, but we really have very few people who are exposed to potassium cyanide in its pure form in a lab. And so that's not very useful in a smoke inhalation scenario. Its toxicity is similar to the effects of what I call other small molecular or mitochondrial poisons. A way to remember most of these is they end with ides or ine. So sulfide, azide, I guess phosphide could be used because zinc phosphide is typically a rodenticide, which we'll talk about on that day. And as opposed to problems like carbon monoxide has, where it binds to hemoglobin in transport, this just gets into the mitochondria and disrupts that last step that cytochrome AA3, shifting into anaerobic metabolism, producing an overwhelming and very rapid onset of lactic acid. And therefore, the height of the lactic acid initially may be an important clue to someone who's suffering from cyanide toxicity, with a threshold being around a lactate of 8. So here's a little diagram of your mitochondria drawn up. You have an inner membrane, you have an outer membrane. Inside the inner membrane is this electron transport chain with all these little molecules in it. And coenzyme Q, which some people take for pseudo health reasons, is one of them. There's other cytochromes. So what happens is as electrons from the TCA cycle get kind of passed down the train, the line here, you generate NAD, you extrude hydrogen ions at each step, and then eventually, if everything's working normally, the ATP synthase, which is something Rob talked about with aspirin being inhibited, fixes everything by bringing the hydrogen back in so you can make ATP out of ADP. Salicylate toxicity inhibits the ATP synthase, the enzyme rectifying function, whereas the small molecular mitochondrial poisons, cyanide, azide, phosphide, inhibit cytochrome AA3 or cytochrome C, or both of them things. So you didn't get to the last point. You get a giant production of lactic acidosis. Typically, if you inhale cyanide in its pure form, you get this very rapid onset of a sense of doom, an increased respiratory rate to sort of compensate for your metabolic acidosis, which is being generated, and then within minutes, decreased cardiac function, actually bradycardia and sudden cardiovascular collapse. And oxygen is present throughout your body, but it can't be utilized by the tissues. So one of the subtle clues may be somebody starts a central line on a supraclavicular or a neck vein, and it looks bright red, like it's arterialized oxygen. It may actually be venous blood, but because none of the oxygen is being removed by the body, by the time it makes it back to the heart as venous blood, it's still hyper-arterialized or hyper-oxygenated if you were to get just a straight up blood gas on it. The blood gas will not tell you if there's cyanide in it. The pulse ox will not tell you if there's cyanide. But if you get a venous sample and they're not on oxygen and the FiO2 is like 100%, the PaO2 is over 100%, that should be a clue to a metabolic poison. And you have to move quickly with the cyanide antidote kit. There are two versions in the United States, one of them sort of being phased out. The new one is the cyano kit. Because the names are so similar, I actually use the name of the chemicals that I want to give, and coincidentally, in the test, they always use the name of the drug in its generic form, and they don't use the name of any sort of shortcut. So you'll hear the cyano kit is really hydroxycobalamin, and the cyanide kit is amyl nitrite, sodium nitrite, and sodium thiosulfite. This is what the old kit looks like. It had all of these things in there, these amyl nitrate poppers, a little bit of sodium nitrite as an intravenous solution, and the sodium thiosulfate as the last of the three things that you give. Basically, the nitrites induce methemoglobinemia. I say, well, why in the world would we want to do that? Doesn't that not carry oxygen? Well, it does. Unfortunately, fortunately, I should say, methemoglobinemia is because it is positively charged, is a very strong attractant for cellular cyanide, which is negatively charged and produces cyanomethemoglobinemia, a neutral substance that still binds to the hemoglobin that your body slowly metabolizes through the liver. The last of the three things we give them in the older kits, the sodium thiosulfate, converts cyanide to thiocyanide by revving up the enzyme in our body, rhodinase, that helps with that in the liver. So if you make someone methemoglobinemia, you'll draw the cyanide out of the tissues, out of the mitochondria, and eventually let the liver do its thing. So we open up the nitrate pearls. The way you dose it is like 30 seconds under the nose and 30 seconds away from the patient so they don't get too methemoglobinemia, although realistically it may only produce a methemoglobin level of around 5, which is not dangerous. Once an IV is started, you can give them sodium nitrite and sodium thiosulfate in that order. do not have to know the doses, not just for this, but for anything on the test. They will not say, no, there will be no question that says, what is the dose of X? They may give doses in a scenario just so you see it, but you don't have to know the dose as the pick one ABCD answer. The risks of these medications are subtle. If you give sodium nitrite too quickly, it's a vasodilator, so you have to watch for hypotension. It will induce profound methemoglobinemia, so the person will look blue and their pulse ox will read 85%, which is scary when you're dealing with a products of combustion inhalation patient who's now dropping their pulse ox. The thing you need to do in that scenario is take the pulse ox off. Once you make someone methemoglobinemia, the pulse ox doesn't work. It cannot interpret the pulse ox accurately. Just take it off. It's an inadequate machine to use in that scenario. People do this all the time, and it's very confusing. Um, some people say don't use the nitrites for smoke inhalation. I think now that we have the next antidote I'll talk about available, I think that's probably true. The sodium thiosulfate can be given. It's pretty benign. It may have some nausea, pain on injection, but it's not very fast. It doesn't do that much. The problems with the kit is a lot of hospitals don't stock it. The old ones, they lost one of the three things in there. Usually the amyl nitrates get stolen for misuse and abuse. We'll talk about that tomorrow. Or the instructions are missing. But the biggest fear is that people have methemoglobinemia phobia, which basically means I'm afraid to induce methemoglobinemia in somebody who's got smoke inhalation that may have carboxyhemoglobin on board and sort of a systematic hypoxia from the cyanide. So they shied away from using this for many, many years. So we talked about methemoglobin changes iron to the Fe plus 3, and normally that binds to water. But in the presence of cyanide, cyanide is preferred over the water molecule. It'll churn the Fe to plus 3. The water will be displaced for cyanide, and that'll draw the cyanide out of the serum, out of sort of the tissues, I should say. What about just sodium thiosulfate? Sometimes it's used. I think it's reasonably benign. It doesn't induce methemoglobinemia. It does cross the blood-brain barrier, so may be helpful for CNS cyanide that's out there. But it basically works in this enzyme rhodinase to convert it to sodium thiosulfate, sodium thiocyanate, excuse me. There is this other antidote that's out there, and it's basically the 2-vial version of the classic styrofoam kit, the cyanide kit. It has the sodium nitrite and the sodium thiosulfate in the same doses in 2 different powderized powders. They're missing the amyl nitrites, which are often misused and abused and stolen. So this has a less of a risk of that happening. And actually, this is the only version that's actually now being produced. The old kits are no longer being produced. So there was a different drug being used in France, and the Paris Fire Brigade reported on this, where they had all these people of house fires. They had an anesthesiologist and a nurse on every ambulance, very aggressive EMS system, and they showed that they were able to resuscitate a fair number of these people who were like moribund from smoke inhalation, with a 72% survival rate and a pretty good neurologic outcome. And despite having cyanide levels in the lethal range, including several that were under CPR. And they were using this drug called hydroxocobalamin. They made them do some human volunteer studies before it was released in the United States. They went to Sweden. They got some college students. They gave them different doses of hydroxocobalamin to see what would happen to them. And they all had some degree of increased blood pressure, which may be okay if you're hypotensive from shock from being poisoned. Most of them, because they were college students, had no problems. But the big thing it did was that it turned everything red. So this is what it looks like when the cyano-kit, and I don't use that term, I use hydroxycobalamin, which is what it is, which is how you'll see it on a test, is mixed up. It's kind of this brownish, murky looking liquid, and you infuse it into the person. 5 grams or 10 grams is the usual dose, and pretty much all of those will make the patients, all their body fluids turn red. Here's a picture from that Scandinavian study, healthy volunteers. You can see on day one, it looks like they had a terrible sunburn, and it took about a week for it all to resolve. But here's a post-mortem of all sorts of things like serum, cerebral final fluid, intravitreous fluid, pericardial fluid, all various degrees of pink. Obviously, vitreous fluid is very isolated from the body, but even that, as isolated as it is, had a slight pinkish tinge to it. And here's a post-mortem heart. Again, not your dark, dusky post-mortem looking tissue, but a bright red thing that, again, only happens from cyanide. So this is what it looks like. It's called cyanokit hydroxycobalamin. It is actually turns the product into cyanocobalamin, kicks off the hydroxy group and binds there. The cyanide binds to the cobalt in it and actually produces vitamin B12. It is not vitamin B12. You cannot give vitamin B12 infusions. This is not what helps. You have to give it as the precursor molecule, hydroxycobalamin. Again, the biggest problems with it is the color problems of the skin, the urine, the sweat, other body fluids. It will interfere with a lot of standardized colorimetric tests, including pretty much all the chemistries. And it may actually interfere with the reading by a pulse oximeter as well. It may overread it, but it's usually not that much of a problem. These are how long the lab interferences last. I don't think they'll ask you any of these, but in general, it's up to a couple of days, and bilirubin falsely elevated for up to 4 days. So who do I treat? Basically, if someone's pulled from a fire and they're obtunded, hypotensive, or they get to the hospital and they're acidotic with an elevated lactate, they probably should be treated with the hydroxycobalamin or treat cyanide poisoning. We might see it locally. All the coyote getter traps are M44 cyanide traps. They have a little explosive thing on it. There's some meat or meat paste put on the top, and the coyote bites it and gets killed with cyanide, which is what the intent of it is. But every once in a while, a child or a dog who's walking in the wilderness will get into these, and sometimes they've been resuscitated with the cyanide hydroxycobalamin kit. At least one episode where a child was recently. So I am going to stop there and see if there's any questions about fumes, gases, cyanide, carbon monoxide, and smoke. Let me go look in the chat, which I haven't been following. So let me go back. So again, someone mentioned, Mark, that the Emergency Response Guide 2020 is available, so you can update your app if you have it on your phone. This carbon monoxide is a risk for water skiers, and people are doing what's called teak surfing on the back of motorboats, not just houseboats. So that's been seen. Yes, that was our very own Enoch standing in front of the hyperbaric chamber, which sadly is closing due to who knows what reasons, mostly budgetary, I presume. But makes our options even more limited, and sort of discussions with medical backup necessary for who we think needs to go or where they need to go sometimes as well. Yep, one more new comment. Right, and they won't accept intubation patients because they don't have the airways. Seattle may be the only place, or Salt Lake may be the only place that'll do these. And so it's hydroxy. It is the standard of care, but I will tell you, there are some places that have bought the dithiodate kits because they're cheaper and they don't buy the expensive hydroxycobalamin. So you have to be able to give option number 2 in some scenarios. I hope you have a question. You what? Or is that the question about hydroxycobalamin? Oh, Psilophyllers disease. So that's like a sulfide. So I briefly alluded to the fact that you can have exposures to the other molecular poisons like azide, which is mostly a chemistry lab phenomenon, and sulfide, which can happen in sewers and sometimes silos. Typically what happens, someone goes down, more likely to go into a sewer, and they pass out from the sulfide. It smells like sulfur, like rotten eggs, and someone goes to rescue them. They pass out, and a third or fourth sometimes show up until they figure out you can't go down there without, hazmat level A suits on to protect yourself, and then everyone gets pulled out. Usually the people who are in the least amount of time are resuscitatable. The people who are in the longest aren't. Silo fillers disease is sort of a pulmonary chronic condition that can happen from sulfur dioxide that accumulates in silos from stored silage, which is hay and other barley, oats, and things like that they may keep there. It's not an acute toxic thing. It's more of a chronic pulmonary disease and something that, I mean, you can do pulmonary function tests on and give steroids for, but basically it's the main treatment is don't keep going in a silo where you're exposed to that over and over again. Um, should I keep going with the drugs of abuse, or do people need a 3-minute break?